I'll take over.
Yes, ma'am. Yes, ma'am. So, welcome to everybody. Today we have a session on obesity and PCOS, the bad, the unhealthy, and the ugly, right? And the moderator for today's session is Lipika ma'am, and she's a managing committee member for the PCOS Society, and she's also the consultant in infertility, sexual medicine, and PCOS. So, I request ma'am to take the proceedings forward. And you can also introduce the experts, ma'am, on the panel.
Yeah, so we have Dr. Sunil Kota. He's a very renowned endocrinologist from the south of Orissa, and he has done extensive work on all academics of endocrinology, and we are fortunate to have him with us. Thank you, Bhai, for joining us. On one request of mine, despite being so busy, our second expert for today's session is Dr. Ms. Shilpa Joshi. She's a nutritionist and dietitian. She's a director of Mumbai Diet and Health Center. She has been practicing for last 20-25 years. She has extensive experience in the field, and she's also always readily available whenever I have needed her for any academic session. Thank you for joining. Our next expert for today is Dr. Nidhi. I think she'll not be able to join for a medical emergency in her family. Her mother just had a recent fracture 1 hour back, so she apologies from her side. And our next expert for today's session, I'm actually very glad to introduce Pallavi. She has been a dear junior, a little sister to me during her PG days when I was doing my SR. Now she's grown up. She has done a fellowship. She's a brilliant student, so I thought of taking her as a panelist. So welcome, Pallavi. Thank you very much for joining.
Thank you so much.
I hope we have an good interaction, a good discussion. So I'll just share my slides. Give me a minute, please. The slides clear?
Yes.
Okay.
Yes,
So when we discussed which non-communicable disease to take with for first the SIG for NCDs of PCOS Society, this was the first topic that came to my mind. So extensively growing these days, and the cases are increasing in leaps and bounds. When I started my practice 7 years back around, there were around 4 to 5 patients out of 10 patients with PCO, and now I have 10 out of 10 patients in my clinic with PCOS, and I think 5 will be obese and 5 will be lean. Lean as per physically lean. They are also viscerally obese. So we'll discuss all of that. Looking forward to some great interactions. We welcome queries as well for our experts. So I'll start with this. So I welcome you all once again on behalf of Dr. Duru and Dr. Sabahat. I welcome all my panelists once again. A good discussion increases dimensions of everyone who takes part. So looking forward to learn so much from all of you today. Now, endocrinology is, I think, one part of medicine which is full of confusions. I think Dr. Sunil will agree. Every time you feel like you've learned enough, more questions crop up. So PCOS is one of the major bulk of reproductive endocrinology. So yes, there'll be always n number of queries cropping up, but confusions is the first step towards clarity. So I hope by the end of today's panel, we'll be able to clear some of your questions. And PCOS, as far as PCOS is concerned, I always call it a Pandora's box, because since 2017-18, I've been doing training sessions, academic sessions on PCO, and every time I call it a Pandora's box because more I dive into it, more questions come up. So when PCOS is linked to obesity, many questions are sure to come up in today's discussion. So to introduce PCOS, it's a syndrome affecting females from womb to tomb. It affects around 6 to 10% of females, very rapidly increasing prevalence. The major bulk of population affected are the adolescent one who come to OPDs with cosmetic concerns, and obviously the reproductive age population who come to us with infertility. Multiple organ systems are involved. And why are we so concerned about this syndrome is that the long-term health consequences are definitely preventable. Therefore, when something is in our hands, we'll work towards prevention. Therefore, the syndrome is so important to us. Now, what is characteristic to the syndrome is a confusion associated with it. There is heterogeneity, there is variation, and there is confusion in everything associated with PCOS. So the confusion is characteristic despite being one of the most common female endocrinopathies. I'll just request everyone to kindly mute yourselves. Shyam, can you please do it from your side?
Yes, ma'am. On it, ma'am.
Yeah. So despite being one of the most common endocrinopathies, a clear comprehensive explanation of pathophysiology is still lacking. It is rational to consider this syndrome as a vicious cycle which can be initiated at any one point of entry. So you do not know where this syndrome originates actually, and altered function at any one point can be the causing of the syndrome. So now this is a very simple diagram which shows the multi-system involvement of the syndrome, starting from the environment lifestyle disruptors, the endocrine environmental disrupting chemicals that we are routinely exposed to because of a faulty lifestyle, the dyslipidemia, inflammation, and the metabolic parameters which are deranged, the DHEAs and the adrenal dysfunction, the adrenal androgens which are raised, the pancreas which hyperfunction, but still there is insulin resistance at the peripheral level, the hypothalamo pituitary axis being affected, where there is an idiopathic hypersecretion of LH. So I think Dr. Sunil will also agree, Dr. Pallavi will also agree. We have many patients where all the parameters are normal, but you have an isolated increase of LH. So that is why it's called idiopathic. You never know why the LH is functionally more compared to the FSH. The LH FSH ratio is now not used to for a lab diagnosis, but however, you can always do a baseline day 2 LH for patients to diagnose PCO, even for IVF patients. Okay. So, and this, what is very significant in this entire loop is the dyslipidemia, inflammation, and the metabolic derangements which is associated with this syndrome. Now, this is a very clear-cut figure which shows multi-system involvement, the chronic inflammation, insulin resistance, hyperandrogenism, which form the basic triad. Associated with that, brain and microbiota. So the entire HPOA axis as well as the gut-brain axis, this also has a very, very significant role. So I think all of us will agree that all my PCOS prescriptions always preferably have a pre-probiotic. It is very, very essential, and gut dysfunction is significant in this group of patients. So we have obesity, we have sleep dysfunction, we have obstructive sleep apnea, we have gut dysbiosis. Lot of chronic inflammation is associated with obesity as well as with PCOS independently, and when both of them are coexisting, you can understand the degree of inflammation. Now, these flowcharts will actually show you certain basic pathophysiologies which we miss while prescribing medicines for a PCOS group of patients. One is gut dysbiosis, one is the hyperandrogenemia and hyperinsulinemia link, and the other is the obesity with low-grade inflammation. So I think all the clinicians present will agree that when you have obesity, there is a low-grade inflammation and inflammatory markers are increased in the body. So even Pallavi, you would have seen that lot of follicles don't grow up with your infertility patients when you go for induction or stimulation, but when you add a low dose steroids, you see the follicles come up. It's because iatrogenic steroids will reduce the endogenous steroid synthesis in the PCO patient. So that is very common. Now, in a rare group of patients, you see that insulin rise is there, but hyperandrogenic features are not there, or either way. The patient has hyperandrogenic features, but insulin resistance is not there. Okay, so what do? Do you give metformin or not? Do you give metformin for obese patients or also for lean patients? So we have to remember that both form a strong connecting link, and irrespective of the BMI of the patient, irrespective of whether she is physically obese or lean, we have to give metformin for counteracting hyperandrogenism as well as hyperinsulinemia for her. Now, PCOS is a lifelong disease. So there is a different age group of patients who present in a different plethora of symptoms. So therefore, it is always a multidisciplinary team which is needed to approach this syndrome and deal with all the complex metabolic features of this syndrome. Therefore, a patient-centered care by a multidisciplinary team, at least comprising of a gynecologist, an endocrinologist, a dietitian, a bariatric physician, or a bariatric surgeon is absolutely essential to approach all the symptoms. And a dermat, obviously a dermatologist is also required to approach the hyperandrogenic cosmetic features of the syndrome. Now, why I have included this slide in the obesity webinar is that we should understand there are 4 phenotypes of PCOS, which have classically been categorized as type A, B, C, and D. But nowadays, the recent 2021 classification in Trends of Endocrinology and Metabolism, this paper has come up where they have phenotypically classified PCOS into A, B, C, and D, but it is renamed according to the metabolic and endocrine imbalance that is seen predominantly in that category of patients. Now, what is more important is that you can understand that there is a non-hyperandrogenic type of PCO, the only phenotype D. has normoandrogenemia. Other phenotypes have hyperandrogenemia, and I think all of us will agree that hyperandrogenemia is strongly related to metabolic dysfunction. Out of all the phenotypes, phenotype A is most important, and obesity and metabolic derangements is predominant in phenotype A and B. So this is what I wanted to conclude. Now, this is how phenotypes have been linked to the metabolic endocrine disturbances, and therefore this is also included in the table that the recent new classification of PCO, that is PCO-EMS, endocrine metabolic syndrome type 1, endocrine metabolic syndrome type 2, endocrine metabolic syndrome, which was earlier called phenotype B, and PCO, which was formerly called, so this is simple PCO, which does not have much of metabolic derangements because the androgen levels are normal in phenotype D. Okay, so this is how phenotype A, B, C have a predominant metabolic onset, and phenotype D has a predominant ovarian onset because it does not have the hyperandrogenemia in it. Now, what is the connecting link? Is obesity the cause, or obesity is the effect of PCO? Let's look into it. So obesity and PCOS are closely linked with obesity being exacerbating PCOS symptoms and complications, particularly visceral adiposity, intensifies all the metabolic derangements of PCOS, and it significantly worsens the manifestations and risk of other associated complications like type 2 diabetes and cardiovascular disease. Now, this is where I like to bring up the chick egg hypothesis, very old hypothesis, long back in the 19th century, but very significant as far as PCOS is concerned. So this is a circular dependency where there is an unclear chick egg hypothesis effect. You do not know which is the cause, which is the effect. So simply to understand, obesity could be a cause or a consequence of PCO. So it is strongly linked, but the effect and cause is unclear. We cannot define one as the cause and one as the effect. Now, I've told you initially in the introductory slide that PCOS is basically a vicious cycle where you have lot of adipose tissue imbalance, lot of adipose tissue endocrine dysfunction, you have insulin resistance, you have androgen excess, and all of this form a vicious cycle. However, you cannot say which is the starting point. So the lower, this figure you can see there is abnormal lipolysis leading on to obesity. However, insulin resistance, abnormal ovarian steroidogenesis, abnormal and adrenal steroidogenesis, raised androgen levels, and hyperinsulinemia all can be a consequence and an effect of obesity as well as PCO. And when both of them are linked, it is strong connection and they can potentiate each other. So from this figure, we can see that adipose tissue, be it visceral or peripheral, has a significant role in both obesity and PCOS. So it could be a consequence of PCO as well as adipose tissue endocrine disruption can be a cause of PCO and effect of PCO. Now the visceral cycle, here the vicious cycle you can see there is increased visceral fat that leads to adiponectin leptin imbalance, causing chronic inflammatory state that leads to insulin resistance, excessive adipocyte action, and leading on to obesity and PCOS. So this is what happens with high fat diet. We know there is an adipocyte imbalance and adrenal androgens and ovarian steroidogenesis imbalance with the high fat diet that we often look onto these days, with the junk food, with the electronic device addiction, with the lifestyle that we are leading these days. So they form again a vicious cycle leading on to PCO. Now with PCOS, there can be two types of PCO. So they can be obese and lean. However, in case they are obese with peripheral fat, they have these sort of symptoms, these group of symptoms. Now, what is the effect PCOS can have on obesity as such? There is always an increased potential for weight gain. There is challenge for weight loss. Now, with obesity, if she has a polycystic ovarian morphology and the clinical signs and symptoms of PCOS, she will have difficulty in losing weight and the metabolic profile will be worsened compared to that of obesity alone. Now, what does obesity have on PCOS? We have all gone through this extensively. It exacerbates the insulin resistance, increases the hyperandrogenism, worsens reproductive issues, elevates metabolic risks, and also impacts the treatment response. So, but I will not agree much with this because lean PCO patients are much more difficult to treat compared to obese PCO patients. Now, this is how, I will not repeat all these things, but these are the strong connecting links of obesity and PCO. You can always have obstructive sleep apnea. This is very, very common in my group of patients. Often I ask them about their sleep history, their gut dysbiosis history. They don't tell often about constipation, loose motion, but when you ask them, they say they have flatulence, they have diarrhea, they have constipation, they are not able to sleep well in the night, they have daytime drowsiness, especially if obesity is associated with PCOS. Now you can see here that I've characteristically mentioned visceral obesity is the one which is the culprit. So it's not about being obese by BMI. It is being having obese like adipose tissue either peripherally or viscerally. But your visceral adipose tissue, your central adiposity is one which affects your metabolic parameters more compared to your peripheral adiposity. Now this is a good table which shows how significantly obesity can affect PCOS. I've already told you about this, and this is the alterations and reproductive endocrine effects of adipokines in obesity. So the right column of the table will show you how significantly fertility parameters and gynecological parameters are impacted by obesity if the girl is having PCO as well. Now, defining obesity. For this webinar, this is very, very important because we're discussing obesity and PCO. So I would just ask all panelists one by one, can you define obesity? So is lean PCO also considered as a case of obesity? Dr. Sunil. Dr. Sunil?
Yes. I'm here only.
So do you want to define obesity by what is the category of obesity that you often encounter in your OPDs? Are all of them peripherally obese equal to obese, or do you assess central adiposities as well, like visceral adiposities as well?
See, for us, the Indians, as we all understand from the FNF hypothesis, we are metabolically more obese even at a lesser weight. That is known to all of us.
Yeah.
And the standard cutoff that is recommended by the guidelines guidelines led by Dr. Anup Mishra. He says the BMI of 25 kg per meter square is the cutoff for diagnosis of obesity, and for overweight, it is more than 23 kg per meter square. And with regards to central adiposity, yes, we do record the waist circumference, which is more than 100 in males and more than 90 females, is definitely indicative of obesity. But then lean PCOS, I would not say these are obese PCOS, but then these are lean PCOS coming beneath these cutoffs, but then they do have also all the metabolic alterations. So we need to treat that. But these are the standard definitions for obesity that we follow.
Absolutely. So lean PCO cases are actually increasing these days. And when you tell them to lose weight, the mother comes with the daughter and she says that I've come to ask you to give some protein so that my daughter puts on weight. So how are you advising her weight loss? Because one of my pioneer teachers from the state always tells that 3 top lines of management of PCO are weight loss, and weight loss. So I guess that's the reason even a lean PCO girl needs to lose at least 2-3 kgs to normalize her metabolic parameters, to correct her lifestyle along with that. And this is a group of patients who are called metabolically obese normal weight females, and they are thin fat Indians. So whatever is the BMI cutoff globally is not same for the Indian population. So this is called a YY paradox, or the Asian Indian phenotype, wherein the cutoff is not taken as 30 as it's taken world over. So now we categorize lean and obese according to the fat percentage and not to the weight percentage. So whenever you have a PCOS patient in OPD, there are always other methods of like diagnosing visceral adiposity apart from BMI. And BMI is now not taken as a cutoff marker for obesity. There are waist to height calculators. There is a normal which can be done with a measuring tape, waist hip ratio, that is often calculated. You have these ready-made calculators on the internet. So just the message to remember is that all lean PCO patients attending your OPDs for a PCO management, please assess their visceral fat by at least these calculators. These can help you. Waist height ratio, waist hip ratio, even the waist circumference, as Dr. Sunil just mentioned. So those are very good criteria to help you know if she's viscerally obese or not. So old terms were obese, overweight. However, new proposed terms are over fat and under fat. So this is visceral adiposity which affects the metabolic parameters. Now, this is what I thought to start my panel with. So we have lot of evidence-based guidelines which come up, but they are based on different population groups. We know how much diverse population we have in our own country. The South Indian population does not match with the parameters with the North Indian population. So it's same for East and West. So with evidence-based guidelines based on different countries' population. We cannot rely on that. So clinical practice points are much more important to look onto, and we can try new therapies as long as we are not doing any harm. So you can put clinical practice points which carry more weightage compared to the evidence-based guidelines. So as far as the patients are concerned, I've seen hundreds of PCO patients over my last few years of practice, and I've learned that every patient is different. Although they look same, they have the same waist hip ratio, they have the same waist height ratio, but when you try to manage them, every patient is different and they require individualization of treatment. So now we'll start with the cases and questions. So we'll stick to the point answers, and we can discuss later on with any queries that you have. I'll be happy to take up questions. Just put your questions in the chat box. So the first case, a 9-year-old girl attained her menarche. She has heavy prolonged flow for around 7 to 8 days. Her body weight is 82 kgs. Her BMI is 33 kg per meter square. She has thickening and darkening of the nape of the neck, groin area and thighs. She also has stria on the lower abdomen. Her BP is 140 by 90 millimeters of mercury. Her mother is diabetic and father is hypertensive. So this is the first case. My first question for Dr. Sunil, how would you investigate the case to arrive at a diagnosis? What are your differential diagnoses for this girl as young as 9 years? How early can you diagnose PCO?
Yes, actually, to summarize the points that you have stated just now, 9-year-old girl, probably early menarche, though she doesn't fit into the definition of precocious puberty properly. Heavy abnormal prolonged bleeding, again suggestive of an ovulation. She is obese with BMI of 33, as you said, and then she also has signs of insulin resistance like acanthosis nigricans stria. So then I would like to add one more point over here. If you could have added few more points for the description of this stria, because we have Cushing's disease also as a differential diagnosis. Purple to red color, violet is stria with width of more than 1 centimeter would be a pointer towards Cushing's disease. And then she also has family history of diabetes and hypertension. And as far as investigations, I would like to divide them into two, the hormonal profile and also the metabolic profile, because we also are looking at the metabolic aspect of PCO as well. So obviously serum total testosterone, free testosterone is something which we do not do routinely because of the lack of availability of the LCMS that is classically required. So total testosterone roughly beyond 50 to 60 nanogram per deciliter would be suggestive of hyperandrogenemia. And at this age, if I have a bit more of history, how fast if you have evidence of hyperandrogenemia, then DHEAS level would also add value. Are we not dealing with a case of adrenal tumor? Because beyond 800 microgram per deciliter would also be pointed towards adrenal malignancy. LHFSH you have already highlighted. We do not do much, but yes, it can be an additional pointer. 17-hydroxyprogesterone can sometimes be useful, especially if you want to have a non-classical or late onset congenital adrenal hyperplasia is a differential diagnosis. We all are aware of the androstenedione by testosterone ratio, which is normally less than 2. We need to remember that androstenedione is predominantly released from the adrenal glands. A ratio of more than 4 probably would point towards adrenal origin, that is LOCA, rather than the PCOS. Sex hormone bind globulin for theoretical sake, yes, but we hardly do it, which would be obviously helpful in calculation of the free androgen index. And obviously, as one part of your question is that the differential diagnosis, to have other differentials, I would like to go for the TSH, prolactin, and you have this stria. So I would like to also rule out the Cushing's disease by doing a morning cortisol, and if required, further proceed with the ONDH, the overnight dextromethasone suppression test. And as far as the metabolic profile, it doesn't differ much. Glucose profile, the lipid profile, liver function. There are few more things that I would like to add here. The bone age X-ray would be really wonderful, and when you have a girl of 9 years, if there is a advancement of bone age, then probably it would point to precocious puberty or congenital adrenal hyperplasia. And I didn't talk about the E2 estradiol in the early phase, but then estradiol, if it is very high, beyond 100 picogram per ml, could probably be also pointing towards presence of ovarian tumor giving rise to early puberty, though it is not a case of precocious puberty. And the differentials, as you asked me specifically, first and foremost, definitely the PCOS is on the rise. So PCOS would certainly be in the list, and non-classical congenital adrenal hyperplasia would be also there. But then we would be looking at some specific features like precocious puberty, puberty, and advancement of bone age. And one more thing is clitorally. We all look
Exactly.
at the clitoris where the if the length is more than 9 millimeter, or the clitoral index, which is the length into width in millimeters square, if it is beyond 15, that would suggest a bit more specific towards non-classical congenital adrenal hyperplasia. Cushing's disease obviously is also a differential central precocious puberty, because 9 years, though it doesn't definitely fall into the zone. And as we've already discussed about androgen secreting tumors. As I understand from your question, how can you diagnose PCOS at this age is
How
really
early? Like, is
how
there any
early.
early cutoff, like early menarche? Is that a suggestion towards her being PCO? Early menarche, early puberty, or premature adrenarche? Anything? Is that suggestive of PCO? Like, if she
Absolutely.
approaches a gynec, is there a probability of her being a PCO? Obviously, ultrasound is not diagnostic at this age, but is there a probability of her being a PCO? Like, how early?
Absolutely.
Yeah.
Absolutely. So if you see the presentation, typical presentation is around 12 to 16 years. That's what the literature says. And it is stated that below 12 years, the diagnosis would be found in around 20 to 25% of cases. And if you have a premature puberty or a premature menarche, yes, that definitely is a pointer towards PCOS. But then the diagnosis has to be kept in abeyance till 2 years post menarche. That's what the standard guidelines are. But yes, of course, we need to keep this in mind. And as you said, the PCO morphology is not going to be of help. We need to establish clinical or biochemical hyperandrogenism and oligoangulation. The criteria again, we all are aware of. For the adolescents below 1 year, don't look at below 1 year after the initiation of menses. From 1 to 3 years, less than 21 days or more than 45 days cycle, or more than 90 days of secondary amenorrhea. Beyond 3 years of menarche, if less than 21 days or more than 35 days, or if there are less than 8 cycles per year. Again, one more thing is, if you have a gap between the thelarchy and menarche, which is beyond 3 years, that also is somewhat suggestive towards the presence of hyperandrogenemia. So that should also raise concern towards probable diagnosis of PCO in future as well.
Thank you, Dr. Sunil. So I was not aware of the androstenedione ratio with testosterone, and that's a good pointer. Basically, we do free androgen index often, SHBG and total testosterone ratio. So I take the cutoff as 5. That was a good point to learn. And yes,
For the
this
one more point to add, actually, for the free androgen index, though we do not do commonly, but then the cutoff, if you want to take, it says early puberty up to 12 years, it says the cutoff is beyond 3, and beyond the age of 12 to 13 years, the cutoff of 5 to 6 would be a good enough cutoff to take free androgen index.
right.
Yes.
Right. So for her, we'll be taking cutoff as 3 at 9 years.
Yes. Yes.
Thank you for your inputs. Okay, Shilpa ma'am, what nutritional advice and lifestyle changes you would advise her? I understand how difficult it would be, like counseling patients at 9 years. So, like, what advice do you give to this age group of girls? Very often they come with obesity nowadays at 8, 9 years.
Yeah. So, first thing that you have to understand that their diets have to be individualized. Like you said, that even though you might have a set of girls or boys at this age who have similar weight issues or BMI, with or without PCOS, it doesn't matter. But diet has to be individualized. And at 9 years, they lead a pretty busy life in the sense that they're going to school, they have fixed time, they have breaks. And nowadays, another thing which has caught on is they go to various classes. So once the school is over, they are running from one class to another, and most of the time they are bored and they are eating. So I think individualization is very important. That's the first thing. Second thing is, rather than giving a diet, changing the food pattern at home is very important. You
Right.
cannot expect a 9-year-old to eat different food from parents or from siblings. So if this 9-year-old has an older or younger sibling who is eating junk, and not gaining weight, and she is gaining weight, you cannot expect these two kids to eat different food. So family counseling is extremely important, and creating an understanding of food per se and relation of food to weight. Lot of times parents, I mean, this is something that I've seen over years of practice, that they say, पर हम तो एक ही खाना खिलाते हैं दोनों बच्चों को, तो हमारा खाना गलत है ही नहीं. There is something wrong with the child, the food is not wrong. And I think that is something which needs to be corrected. So there is what is required is overall understanding and correction of diet to the whole family. And of course, this girl is going to grow. I mean, we have not done her, whether she's going to grow further by, her bone age, but we know that she's going to grow. So reduction of calories. So all these LCDs,
Absolutely,
VLCDs,
yeah.
are or intermittent fasting or keto diets, none of this is going to work with
Right.
her. So it has to be a very well balanced planned diet with enough breathing space so that this child feels that she is normal and not different from others. Because if you're going to put her and tell her ki लौकी का सब्जी खाओ और टिंडे का सब्जी खाओ, तो she's going to be very, very disheartened at this age. So I think a very, very carefully planned diet, keeping her likes and dislikes in mind. And I think also talking to the child herself, because a lot of times we do not give too much importance, but children do understand a lot. They are also worried about the way they look, the way their health is.
Yeah.
So I think, and also introducing a good amount of physical activity, though,
Right. Yeah.
another very, very important part. Whether, she's a young girl, so maybe a dance, or maybe a sport, which girls enjoy more, or even a sports which she can play with her siblings or whatever it is. So I think introducing sport again is very, very important. So I think it's a holistic thing. It's not just one, blanket diet which has to be given to the girl. Yeah.
Right. So two very important points which ma'am mentioned is that even the same two siblings are from the same family, one will be obese and one will be lean as far as the peripheral look, physical look and the peripheral adiposity is concerned. So the mother always tells that we cook the same food in the family, both the siblings take, and why is she obese? And my other younger one is, she's normal weight. Maybe she has not put on weight, with time she'll put up, or maybe she's viscerally abnormal. She's not looking peripherally obese, but she might have abnormal visceral fat, and she's also having same metabolic derangement as the other sibling. So that's very important. Another point which ma'am mentioned is changing the home cooked food, for the entire family, the pattern of food, the diet, some basic tips like taking early dinner, not too early, because if they take too early dinner, what happens is they, they crave into late night snacking, which is often unhealthy. Nobody takes an apple late night while studying. So, so not very early dinner, but early dinner, quite an early dinner, plenty of water. So that's very important to counsel her to include some form of physical activity. If she's going for extracurriculars, let her choose some hobby or some classes which she'll enjoy so that she can stay with that for a long time. That's very important. Okay.
Another thing which I did not mention is to look after her sleeping pattern.
Exactly, ma'am.
I
That's
think
very, very important.
because 9-year-olds also take their mobile and they are on Instagram.
Exactly,
and God alone knows, but they are. So, so not giving them phone, I think after 8 p.m. is the biggest intervention you can do.
Right. Very, very important, ma'am. Very important point. This point should be very strictly noted because, ma'am, most of my either adolescent group of patients or the IT professionals who come to me for infertility, with PCOS, they often say that 8 घंटा सोते हैं, रात को 3 बजे सोते हैं, सुबह 11 बजे उठते हैं. So that's also 8 hours sleep. So two important things which needs to be counseled is your mobile should not be taken to like your bedroom. That's very important. No cell phones at least after 8-9 p.m. That's again important because that is how your sleep rhythm is getting altered. Your entire sleeping pattern is getting altered because of the mobile cell phone light. And even the initiation of sleep should be by 9 to 10 p.m. And you should wake up early by 4:35. It's not sleeping from 3 a.m. to 11 a.m. So the pattern of sleep is also very, very important. Like metformin, your anti-androgenic medicines, all of this is not going to help till your sleep pattern is not corrected. You'll see she'll stick to a lifestyle, she'll stick on to a very good diet and physical activity, but she'll not be able to lose weight. Why is that? Because of unhealthy patterns of sleep. They often watch these web series and all late nights, so they sleep late, they wake up late, and then they don't have any physical activity in the morning. So sleep is another very important part of lifestyle which needs to be counseled on. Okay. Dr. Pallavi, is early menarche indicative of PCO? What should you advise and counsel her for her menorrhagic cycles? Because she's very young, she's just 9. And what medications for PCO can you give? Because we know as early as 9 years, you'll not be able to give her OC pills with anti-androgens. So what will be your advice for her menorrhagia? What will be your medications for her, this girl, around 9 years? And we already know that she doesn't need an ultrasound for diagnosing PCO.
Yes, ma'am. So early menarche can have multiple differential diagnoses, but it has been observed that especially early adrenarche and early menarche can be it can lead to PCOS in later life, because most of these early menarche patients, they are idiopathic, but they have the common risk factors, like they can be low birth weight or they have maternal risk factors in utero exposure. Especially this patient, she has obesity and already developed insulin resistance features. So this early menarche and early adrenarche, especially with hyperandrogenism, are indicative of future. They are a risk factor for future PCOS. They can be. So coming to this particular patient, as sir has clearly told about all the differential diagnosis, there are several aspects. One is that she is a 9-year-old who got her menarche. The cutoff for premature or precocious puberty may be less than 8 years, but she might have developed her thelarche or adrenarche before 8 years of age. So she is at a risk factor. So we need to rule out all the other risk factors like gonadotropin independent precocious puberty. Along with that, because she has BMI of 33 and she is having insulin resistance, so we must rule out all lipid profile. OGTT has to be done, and especially this non-alcoholic fatty liver disease LFT has to be done this patient. And as ma'am has clearly told this, the main intervention has to be diet and lifestyle, healthy sleep pattern, and lack of decreasing the digital activities. So for the menorrhagic cycle, because she's 9-year-old, we have to look at her bone age. If she has reached her final adult height, if she has not attained it, and then we can consider, because she's 9-year-old, in GnRH agonist this for this patient till the age of 11 years, or at least a bone age of 12 years. So that will decrease her, stop her menses, and allow her further height to develop. And we should always take into account, because she's a puberty having menorrhagia, so we should always rule out anemia, and anemia correction has to be done for that reason. And usually OC pills are not recommended at or so early in the age for her. So if we can give her GnRH agonist for at least 2 years, she can improve her anemia, and after that again stopping that, she can regain her menstrual cycle, and we can reevaluate her at that time. And coming to ultrasound for her diagnosis, for the diagnosis of PCOS, ultrasound is not recommended at this age, because she just had her menarche. We should give her time, reevaluate after 2 to 3 years. But in this particular patient, because he has a early menarche, just to rule out any ovarian cysts or adrenal tumors, she can undergo a ultrasound to rule out all those things.
Yeah. So ultrasound not for polycystic ovarian morphology, but for other abdominal conditions, abdominal ultrasound can be advised. That is one take-home point. Second is, after onset of menses, we should wait 2 to 3 years for at least 4 years for the menses to normalize. That is another important point. Till the epiphyseal closure happens, we cannot give her any OC pills, because that will cause a stunted growth. That's again important. And we should understand that, Dr. Sunil had already mentioned that her thyroid profile also needs to be done, because she could be hypothyroid along with these menorrhagic cycles. So that again needs to be evaluated, and a strict lifestyle change for her. So, like when she's had her menarche, I gave her a diagnosis as tending to PCO till further workup is complete, because you cannot do all the hormones for her just to keep ruling out causes. It's very, like financially also the patient should be capable of doing all the, the panel of tests. So, like nowadays laboratories write PCO panel. It's not possible for a patient to do 70 hydroxyprogesterone, this, that, everything on the first go. So first you counsel, you win her confidence, let her have faith in you, start some medications thinking her to be a PCO, because definitely premature adrenarche, thelarche, pubarche, menarche, these are suggestive of her becoming a PCO. And nowadays we have younger and younger PCO girls coming up. So the diagnosis was that I gave was tending towards PCO till further workup is complete, because till you're doing no harm, just try to approach the patient in a better manner with more nutraceuticals. Along with lifestyle advice, you can give her some resveratrol, vitamin D, some multivitamins, some antioxidants that she can take along with her normal diet. So this was what I found, that prenatal hyperandrogenism, just like Dr. Pallavi mentioned, and pubertal hyperandrogenism are both characteristic of PCO, depending on how much the in utero exposure for the fetus was there. So, that could be an early onset of menses, that could be the reason for early onset of menses. And definitely PCO is possible at this age of 9 years. However, the stria should be clearly examined, the clitoris should be examined, physical examination in detail should be done, followed by laboratory investigations to point out a case of premature, onset of PCO. So we can just try tending towards PCO. Even for this group as well as adolescents till 19, we cannot practically write PCOS at this young age. So this was what I found, because it affects all age groups, starting from fetal life to adolescent. The onset starts in utero. Therefore, this is again a strong possibility of being a case of PCO. So this was the food pyramid. I think ma'am has mentioned everything in details. So the food pyramid starts with the maximum of vegetables, salads and fruit, and should be ending with the least amount of fat and oil. So this was a very good pictorial figure which we can keep in OPDs just to counsel our patients regarding what their diet should be. Okay, Dr. Pallavi, one question is there. Which GnRH agonist to be given and what dosage to be given for case 1?
Yes, ma'am. So here we can give a long-acting triptorelin or leuprolide 3.75 milligram. It can be given every 28 days, or 11.25 milligram IM can be given every 3 months.
Okay, so that's a long thing, long like Zoladex, something like
Yes.
that can be given once every 3 months, deep intramuscular. One more question is, what medication should be given to at 9 years age? Dr. Sunil, can you give a list of at least 5 common medications which can be used for this girl with these complaints, with a family history of metabolic syndrome already, with both mother and father being diabetic and hypertensive? Can we give her some medications which will prevent or delay the onset of these metabolic derangements in this girl?
The only medication you asked me to list 5, but I would be going ahead with only one. That is only metformin, because we have some studies suggest that where it can be used for child up to 6 years as well, where metformin has been shown to be ameliorating a good amount of insulin resistance. So for this particular
Absolutely.
patient, as you've already stated, we cannot go for OC pills, and lifestyle modification. Silpa ma'am has already told us. So only thing my preference would be only metformin. Obviously, if you have additional findings like hypothyroidism, hyperprolactinemia, probably that would require constitution of new drugs. But then apart from that, nothing else.
So would you advise nutraceuticals like myonostal, resveratrol, which bring down insulin resistance, androgen excess as well, they're not basically drugs, so they are mainly fruit extracts which can be given safely at this age group, where we cannot give too much of anti-androgen or estrogen containing ocipils and all. So can nutraceuticals help, like benfotiamine or chasteberry extracts, some which are clinically proven, like selenium, zinc, which are proven to be therapeutic in PCO patients?
Yes, actually, I have seen a good amount of studies advocating the usage of these molecules, especially in these age group, to suppress the hyperandrogenemia associated with insulin resistance. But if you ask my personal opinion, I do not use these medicines. But then yes, there are some studies to suggest it, and I don't think any of the major guidelines have endorsed its usage. But then yes,
Absolutely,
so
there are no guidelines, and all RCTs always are inconclusive regarding nutraceuticals. I just wanted to know your personal experience, so you don't give these in your prescriptions. Okay.
Absolutely.
Okay. So this is again a simplified version of the food pyramid. So I've taken both the questions of the chat box. Yes.
Can I come in one here? Actually,
Sure.
I had my thesis topic on bariatric surgery for remission in diabetes during my residency. So one of the questions was how early.
Then we have how early can we go for
bariatric
bariatric surgery? Yeah.
So the concept is the skeletal maturation and pubertal maturation has to be complete. Then only you should be subjecting the child to bariatric surgery.
Okay.
So probably for a girl beyond 13 years, for a boy beyond 14 years, and for the pediatric age group, we do not use the BMI cutoff. We use the percentile. So where the BMI percentile more than 140% without any comorbidities, or more than 130% with comorbidity, that is the indication. And standard thing is Tanner stage 4 has to be crossed, and if you look at the bone X-ray for the bone age, it has to be minimum 90% for that particular age, so that we can safely conclude that the skeletal and the pubertal maturation has been completed. Then you can subject the patient to bariatric. That's all. I'm done.
Very
Thank you.
important inputs, very important inputs. Thank you so much, Dr. Sunil. So very important inputs. So if the bone age is it is complete and the Tanner stage 4 is like she has achieved Tanner stage 4, then only we can think of having a bariatric surgery done. I just had an idea beyond 16, I think we can go, because in one of my last webinars, a bariatric, like average, she told 15 or 16 maybe. Beyond that, we can think of, because she's too young to go for bariatric surgery, because still her, she has achieved a full growth spurt. She's still yet to complete her growth spurt and all. There we cannot think of bariatric surgery, despite she being morbidly obese at BMI 33 for her age, which is too high, and metabolic syndrome running in family. Still, we cannot think of bariatric surgery for this young girl. Now, this is the workout activity pyramid. Yet the entire summary for this pyramid would be engaging in any hobby which will help you lose calories and which you can continue for your lifetime. So, it is cut down on sitting and watching TV. Sitting in one place should be cut down. Therefore, it's at the peak of the triangle. And the broadest part is walking out, like walking every now and then you should get up from your workplace and just walk a bit and again sit in your place. So this is how the activity pyramid has been designed. Now, take home points. I think enough has been discussed about this case. Lot of things we have already discussed. So I've summarized every panelist point also. So I'll skip this part. Now we move on to the second case. I think there's one question in the chat box.
No, I have
Okay.
only answered to the queries actually.
Okay. Yeah. Thank you. So we move on to the second case. 16-year-old obese girl with a BMI of 34 kg per meter square presents to the OPD with irregular menorrhagic cycles. She has acne, frontal hair loss, excessive unwanted hair over chin, breast cleavage line, and lower abdomen with a FG score of 7. Her maternal grandparents are diabetic. She had the following reports: fasting serum insulin, although not advised by all clinicians. She had these reports with her when she came to my OPD. It was 54, RBS was 118, glycosylated hemoglobin was 5.4, TSH was 6, prolactin was 34. She's brilliant academically and studies mostly at night. She told me, you'll not understand the pressure of exams these days, and night is a time when everything is quiet and I remember well. And she told that she was unable to sleep well at night. So she had frequent breathlessness episodes often, and therefore she preferred staying awake at night reading, and when she becomes tired in the morning, she used to sleep early morning. So that was her routine schedule. Now, my first question to Dr. Sunil. So this is a very, very common case scenario. I think you will agree, Dr. Sunil, that we come across in OPDs these days, very common cases. So how do you further evaluate her? Any tests for her specifically you would recommend with this type of lifestyle and her daily routine? Clinical relevance of modified FG score if you do in your OPDs, and how would you differentiate her from congenital adrenal hyperplasia, the non-classical type, late onset ones?
Yes, actually, yes, as we can see the questions displayed in the PowerPoint, I would be just summarizing all the points that you have stated. Obese girl having irregular menorrhagia and ovulatory cycles. She has all the features of hyperandrogenism in the form of acne, frontal alopecia, hirsutism. FG score, I think, is 7. So for Asian females, the cutoff is taken 6. Insulin resistance, as you already stated, that we do not do routinely the fasting insulin, but then 54 is markedly high, suggestive of insulin resistance. She has subclinical hypothyroidism with TSH of 6, hyperprolactinemia with PRL of 34, and sugar-wise, she looks decent good. Lifestyle is sedentary, studies at night with all those points backing her dates, and she also has obstructive sleep apnea, which was aptly highlighted by you during your presentation. So the question that comes to our mind is, what should we be doing? So again, as I have already stated in the previous case, the total and free testosterone cutoff being 50 to 60 for total and 5 for free testosterone. DHEAS, yes, if you want to complete the evaluation profile, increase in adrenal androgen excess, the androstenedione, as I've already stated, I would just like to reiterate, androstenedione by testosterone ratio, it is normally less than 2. In adrenal origin hyperandrogenemia cases, the ratio goes up to 4. 17 hydroxy progesterone early morning would certainly be there. Non-classical congenital adrenal hyperplasia. And if the 17 hydroxy OHP is borderline, like the cutoff is beyond 2 nanogram per ml, up to 10 nanogram per ml, this is indecisive zone. You have to go for the ACT stimulation test. If post ACT stimulation test, the cutoff the stimulated value goes beyond 10, that is confirmatory of LOCA. And again, yes, I've seen people doing the SHBG to go for the free androgen index. Ultrasound, as you've already stated, this age group probably would not be that much useful. And the other contributing factors. See, the prolactin is mildly elevated, but as you see, there is a trough and peak type secretion by that of the prolactin. We would like to go for a repeat pooled sample prolactin. That would be really useful. And if prolactin comes beyond 50 to 60, yes, you need to have a suspicion. And if it is beyond 100, probably you need to think of pituitary origin. And obviously, before that, one reading of elevated TSH, which is below 10, doesn't take you anywhere. But then, yes, we need to repeat it to establish the diagnosis of subclinical or clinical hypothyroidism. And yes, a sleep study is something that I routinely do. And with regards to the hirsutism score by the Ferryman-Galway, which is an assessment of extent of terminal hair growth in 9 androgen sensitive areas. I'm not going to list out those, we all are aware of, but then the score is for, especially for Asian females, beyond 6 it is established as hirsutism, beyond 8 it is moderate, and beyond 15 it is severe. Sometimes, apart from using it as a quantifying marker for clinical hyperandrogenism, we also use it to monitor the response to therapy. But it has its some limitations because it is dependent on the observer. And sometimes what happens is locally there is a high score which would not add to the maximum total score. And there are some androgen sensitive areas which have been not taken into consideration, like side bumps and buttocks, and their correlation with the androgen level is modest. And as far as the differentiation between PCOS and non-classical, that is something very useful for all of us as clinicians and all the PG students who would be watching. So I would like to start with the family history. Non-classical congenital adrenal hyperplasia, as we all understand that the mode of inheritance is autosomal recessive. You may find a history of consanguinity in the marriage, and in PCOS, yes, there is a family history of diabetes, hypertension, and other markers of insulin resistance. Menstrual cycle, especially both of these conditions would come to you with irregular cycles, but the PCOS has anovulatory cycles. That's why it would be associated with menorrhagia, which is not common with the non-classical CAH. And hirsutism or acne are much more severe in non-classical congenital adrenal hyperplasia. If you look at the FG score, it would be beyond 12, 13 like that. And signs of obesity, insulin resistance would be more common in PCOS, which is not there with the non-classical congenital adrenal hyperplasia. And the 17 OHP obviously is the diagnostic. Beyond 2 nanogram per ml basal, you need to be strongly suspicious, subject the patient to the ACTS stimulation test. If it is beyond 10 nanogram per ml, it is diagnostic. And ovarian ultrasound, the polycystic appearance would not be there with the non-classical congenital adrenal hyperplasia. And as far as the therapeutic aspect is concerned, there would be significant response to the glucocorticoids if you have a LOCA as the diagnosis, which would not be there with the PCOS. And yes, I think you asked also about the management plan, and I would not venture into the oral contraceptive aspect. But then yes, anti-androgen is the one which we can look at if hirsutism is there. Metformin certainly for insulin resistance. And lifestyle modification, yes, it is Silpa ma'am's forte, but then it is the first pillar for treatment of any particular patient. Then you had this borderline elevated prolactin and TSH, you have to settle that issue by repeating it. And sleep hygiene, as Dr. Lipika was avidly alluding to, I would also like to emphasize upon that. And also a sleep study would also be equally important, because we have seen obstructive sleep apnea giving rise to early onset hypertension and diabetes. And with the usage of CPAP, the risk to progression to over diabetes and hypertension is coming down significantly. Over to Dr. Lipika.
Yeah, so I just extensively, Dr. Sunil has explained everything. I just wanted to give one take-home point here, that there is strong penetrance of hypothyroidism and hyperprolactinemia simply by being PCO. Like we have seen around, I think Dr. Sunil will also agree that there is a coherence of around 65 to 70% patients being hypothyroid. I have seen extensive hypothyroidism. That's why this is a, like this is a baseline test which I do on first visit. If she is fasting and I do a TSH and prolactin for her, because there is a strong penetrance of hypothyroidism and hyperprolactinemia. And I routinely ask about her like breast complaints or whether she has nipple tenderness or whether she has unilateral or bilateral mastalgia. That's also important, especially at this age, because they don't tell about that complaint. They are more concerned about their cosmetic concerns and their body image. So that's what I wanted to tell, because 34 is something which is borderline, which is confusing, which is not a like a definite cutoff. So pooled prolactin test would here carry more weightage here. I think Dr. Sunil, there is one question for you in the chat box.
Yeah, I've been answering that. I was typing that. So yes, the Synacthen or the ACTH is not avidly available when we go for 250 international units IV followed by 1 hour of 17 OHP. But then Acton Promiatom is one such alternative which is widely available, where you give 20 units intramuscularly and 1 hour post that the 17 OHP, the cutoff, if it is going beyond 10 nanogram per ml, yes, you can actually use it.
Okay, my next question for Shilpa ma'am. Any specific diet and lifestyle changes? Because we can see that she has an entire erratic lifestyle pattern throughout the day. And whenever you counsel them to sleep early and wake up early and study, that's what they say, that you don't understand the pressure of these days studies, ma'am, the competition, parents' pressure that we have to top in the exam and all that. So late night is when I find it conducive to study. So how do you counsel this group of patients? They're adolescent, teenage, and it's very, very difficult to counsel them. They have their own set of thoughts. So any specific diet and lifestyle changes you would recommend her, and how difficult it is to counsel these patients for you?
So I think first thing about any kind of lifestyle issue is a lot of counseling and understand, getting the person who is living with this problem understand what is happening. I think we need to talk to her to get her sleep pattern corrected. Very, very important, because correct sleep pattern will also give correct food pattern. If the girl is keeping up whole night to study, I am 150% sure she is eating, and she is eating only processed food. So that's the first thing, because at night there is very little available other than processed food. Even if you're ordering on Swiggy, Zomato, you are still ordering processed food. That's the first thing. So I think that is very, very important. Second is, again, getting some amount of physical activity to this girl. She's brilliant. She wants to, whatever entrance exam she wants to write, we really need to work on her physical activity pattern, which is very, very important. Third thing, I at least this is what I see in practice, is these young girls with PCO, they go through something something like reactive hypoglycemia, wherein they are perpetually hungry to after eating. So they are going to tell you, we never feel full, and we are always craving for food. I think that is something which will need to be addressed in this girl by giving her a high protein, high fiber diet, so that anyway her fasting insulin is high, but and I'm sure her postprandial will also be high. We need to work on foods which are lower in carbohydrate, higher in fiber, higher in protein, so that we do not get these spikes of blood glucose and insulin, and thereby drops. Both go hand in hand.
So she has this significantly this hunger spikes, ma'am, when she stays up late. So that was what she asked me in the OPD as well. That like 1 a.m. I feel hungry, and you say that it's not practically feasible to go and have an apple at 1 a.m. because I need something tasty, because I have to stay up again late night till 4 a.m. early morning.
No,
So what would you advise her, ma'am, to take around in the dinner so that she feels full for a longer time?
So that's what I'm saying. Having a protein-rich dinner. So if she's a vegetarian, maybe sprouts, maybe dal, maybe products made out of them. If she's a non-vegetarian, a generous piece of meat. I think that is something which is very, very important. White meat or fish or whatever it is. It's very, very important that she eats that. Eats a lot of fiber, vegetable, less fruit, more vegetable. I think that's very, very important, because fruits will again give reactive hypoglycemia.
Exactly. Yes, ma'am. That's a very good point.
If she eats apple, she's going to be hungry in after apple. She's not going to feel full. So I think vegetables are very, very important. A lot of fluid intake is very important. And I think this is a good time where you can introduce her, if she is open to it, to either a meal replacement, especially if she's studying at night, to have it, or a protein drink. Both are
Protein
different
drinks,
things.
right?
Both are different things, but you can, depending upon affordability and what she's doing, or you can even have homemade protein drinks. Like Sattu is a very, very nice
Exactly.
option,
Yes, ma'am.
which she can.
That's a very good nutritious thing which is prepared at home, ma'am. So
Yeah.
very like two very important points pointed out by ma'am. One is like plenty of fluid intake, fluid in the form of water, in the form of like dahi sharbat, in the
Nimboo
form of
pani.
homemade juices or anything, but fluid intake, dal ka pani, that gives you a lot of fullness for a long time, and that's healthy as well, and you don't put up calories with that. And the other thing is that having raw or semi-cooked vegetables at night or a piece of meat, as she told, and protein shakes with thin dilute milk, which is because milk has androgen, so too much of milk is also not advisable for a girl with PCO. So a thin dilute milk with a protein shake, which can be cold or hot or anything, but preferably normal temperature, ma'am, because I think protein will coagulate more if you heat the with the
No,
like
but
high
we
content
don't
of
want you
protein.
to have any kind of proteins in milk. It has always to be in water.
Water, yes,
The
ma'am. That's
reason
again,
is
yeah.
either it's whey, so you have separated it from milk to be whey, or it's a vegan protein, which is like
Yeah.
a pea protein or a soy protein or whatever. So please have protein in water. However non-tasty they are, that they are okay. And metformin is not tasty either. So we have to tell them to take it like medicine and drink it. Yeah.
Yeah. Okay. So I think this will be an extensive discussion, Dr. Sunil. Newer anti-obesity drugs, apart from the ones which were used long back, newer specifically GLP-1 analogs, any mention of newer drugs and their efficacy for this group of patients, wherein I don't think she'll stick so much to lifestyle because I've counseled her for an hour or so. Maybe I learned so much new things today from Shilpa ma'am, but I counseled her, I talked to her at a stretch, but I think will you advise some anti-obesity drugs along with metformin for this girl? I had given her nutraceuticals also, although she had a weight loss, but it was very modest. I mean, she was not content with that, and her clinical features even didn't improve with that. So, any anti-obesity drugs which have come up, which can be used in this group of patients, 16-year-old.
Yes, actually, the age becomes a bit tricky for sure.
Yeah.
Because I think you are specifically asking about the newer GLP-1 receptor analogs. The Monjaro has been launched 2 months back, and I think the injectable semaglutide Wegovy is going to be launched in India probably in a month or two. But looking at the age, 16 years, big no to them. Beyond 18 years of age, these drugs are approved. So we should not be using it off the label as well. So we have some studies as to how usage of Orlistat has been helpful in as far as amelioration of all the metabolic derangements and others. But Orlistat has not been a very uh, uh, important molecule or very impressive molecule, I must say. But then yet it can be used as an adjunct, which says that the ESW, extracted weight from the meal, comes to around 3 to 4 kgs and around 4 to 5% at best. So beyond that, it doesn't give benefit. So yes, it is one such option, but not a great option at this age.
Yeah. So any just a small input regarding GLP-1 analogs which are in market, obviously not feasible for this age group patients, but any inputs from your side about the GLP-1 analogs? They are too much in rampant use. People now have researched the net and come to us. So we need to know something about that before we speak to them because they're all educated from the net. So just for some take-home points for clinicians and for postgraduates who have joined us, like any inputs and any important points which we should know for counseling.
Yes, see, actually, there are two GLP-1 receptor analogs that are there in the pipeline now. The first one is already in the market. The first one is the tirzepatide, which is GLP-1 and GIP combined analog, which is launched as the Mounjaro just 2 months back. And the mechanisms I would not delve into much. And if you look at the overall clinical profile, there are Surmount trials and there are Surpass trials. And for diabetes, it has got 3 indications. First of all, for type 2 diabetes, where it is associated with 1.7 to 1.8% A1C reduction. For obesity, if you collect the data from all the SURPASS trials put together, then it states that after a period of usage of 5 to 6 months, the weight reduction is to the tune of 18 to 20%. So that is probably stretching up to the bariatric surgery advantage level. And it is also the first molecule approved for treatment of obstructive sleep apnea as well. This is the only molecule. And if you compare, semaglutide has not yet come into the market, but then recently, 10 days back, there was this publication of SURMOUNT-5 trial, which is a study done on around 700 patients for about 72 weeks, and it is stated that the weight gain arising out of Mounjaro or tirzepatide is significantly higher than that of the semaglutide. And the percentage of population achieving more than 25% weight loss is significantly more in favor of tirzepatide than the semaglutide. And also the chances of side effects. The side effects are typically the GI side effects like vomiting, nausea, altered bowel movements. These are significantly lesser with the tirzepatide because it has got dual action on GLP and GIP rather than only GLP-1 based action by the semaglutide. So yes, practically speaking, around 15% of the people who are on GLP-1 receptor analogs would go on to have all these gastro-related issues lasting for about 13 to 14 weeks. But co-prescription of PPI and pre-probiotic majorly does the trick in most of the cases. But then again, the studies state that 3 to 5% of the people would go on to be majorly intolerant to this molecule, calling for total cessation of this molecule.
Yeah, I just had one question. I don't know whether it's relevant or not. Do patients have significant mood swings and like anger spikes and all with GLP-1 analogs? Is that like clinically significant enough?
See, actually, post-bariatric surgery, with the kind of weight loss that it gives, there has been reports of significant mood swings. But these kind of molecules giving rise to weight loss to the tune of 15 to 20% have come very recently. And if you look at all these SURPASS trials and SURMOUNT trials, none of them are talking much about it. But then, yes, on a long run, we are definitely looking forward to a scenario where there would be definitely all these psychiatric issues and mood disturbances in the long run. That is for sure.
Okay, I think Dr. Sunil, do you want to take the question on? I think it's the same thing. And does bariatric surgery help us in relieving symptoms of obstructive sleep apnea? One very important key point is that we had a W3 webinar of the PCOS Society on sleep and PCO, wherein we had like sleep physicians with us, and I got to know that the sleep apnea related to PCO is not absolutely in obese PCO only. So even lean PCO patients also have the sleep apnea, which may not be of the obstructive variant, because there is a lot of muscle laxity. That's what they told. And the hormonal imbalance in both the group of patients was almost similar. So the sleep apnea was also predominantly seen in the lean group of PCO patients as well. Do you agree, Dr. Sunil? Because you also work on sleep.
Yes, absolutely. In fact, I do not exactly recollect the presentation by one of the authorities who was the pioneer author of the sleep study, if you recollect that, during my endocrine residence days. And he has shown us at least 7-8 videos where I'm talking about 2014, during my study time. And then also he showed us a number of lean people having snoring and other aspects. So the sleep apnea is not something which is only restricted to obese people, but then yes, predominantly to the obese people. As far as this question is concerned, there are two different types. First of all, the restrictive variety bariatric surgery, and there is a malabsorptive variety. Restrictive variety, to simplify, it is the sleeve gastrectomy or a gastric banding, and the malabsorptive variety is the Roux-en-Y gastric bypass. If you look at the efficacy and long-term data, the Roux-en-Y gastric bypass is the best one. But then it comes with a number of disadvantages like malabsorptive component, the bacterial overgrowth component, the NIPHS, the non-insulinomatous beta cell hyperplasia syndrome. So yes, the options are two, either a sleeve gastrectomy or a Roux-en-Y gastric bypass. What extent of weight loss you want? The restrictive would give rise to weight loss of 30 to 40, and the malabsorptive would give rise to weight loss to the tune of more than, yes. Depends on that.
Yeah. Okay, so Dr. Pallavi, what hormonal and non-hormonal medications you would like to prescribe for a girl apart from lifestyle changes, this 16-year-old girl, and for a cosmetic concerns, because she was very concerned about her cosmetic, features and for her body image, and she was not able to go to, public functions and all, which she felt that she had always a negative self-image about herself. So would you immediately refer her to a dermat for cosmetic approach, or would you still try to manage her for initial 3 to 6 months under your guidance?
Yes, ma'am. So for this patient, as she has this obesity, along with she has irregular cycles with heavy menstrual bleeding. Along with that, she has features of hyperandrogenism. So the best combination, I think, and she also is likely to have insulin resistance. So the best combination of hormonal medication that I would like to give her would be a combined ocipil, along
At
with
16, Pallavi, you would go for occipils?
yes, ma'am, because 16, I think we can give ocipils because it will not much affect the bone age because it is a low dose estrogen containing, and she also has the features of hirsutism. So
Yeah,
that will be best
like
managed.
hyperandrogenic features are there. And what
Yes.
is your combination? Like, would you go for an anti-androgen with ethinyl estradiol 30 microgram, or what would be your ideal
Ma'am, the
combination
dose of
choice?
ethinyl estradiol can be vary from 20 to 30, but the choice of estrogen progesterone does not matter in case of management of this PCOS.
Okay.
And ciproterol acetate usually is not preferred in as a first line in case of PCOS. And coming to her Ferriman Galvez score, which is 7, so which is a mild variety, but there is a thing that for this to the ocipil to act on the features of hirsutism, she has to take it for at least 6 months. So any intervention has to be for 3 to 6 months. So it also depends on the patient's psychological state. If she is very much anxious or is worried about her body image, then we can counsel her that she can take it for 6 months, 3 to 6 months trial, and then if she is not controlled with that, she can go for. Otherwise, for her psychological satisfaction, she can combine both the treatment together.
Okay, so that's Dr. Pallavi's line of management, but still there is no concrete evidence-based guidelines, even in the international evidence-based guidelines of 2023, regarding what is the cutoff age beyond which you can actually prescribe like anti-androgen containing ethinyl estradiol combination occipils, because there is, like I told you, population variance is there, lot of population variation is there, where even the international evidence-based guidelines where 70-80 countries sit together and they, they represent their societies and they give guidelines, even those guidelines cannot be applied. So number one take home point from this case is I would write her tending to PCO, because she's in the like adolescent tending to PCOS, because 8 years post menarche is when you can actually stamp her a case of PCOS. That's one. She's okay, she's morbidly obese, that is one. Just like Dr. Sunil mentioned, some safer anti-obesity drugs. Lifestyle changes is obviously the cornerstone and first line management, but I would still give her more of nutraceuticals like resveratrol, myonostal, or some antioxidant. Maybe one formulation will help her. Vitamin D can help her, and there should be strong emphasis on lifestyle changes. So that is what is very important. And at least after 3 months of these conventional modalities of treatment, you can go for a dermat consultation and doing some like her acanthosis reduction or some laser or cosmetic treatment for hypoandrogenic features, because till your internal milieu is corrected, that's how I counseled her. Any external therapy of cosmetic treatment is not going to help you for a long time. So this is how hyperinsulinemia and hyperandrogenism are strongly linked to all of the metabolic derangements, especially obstructive sleep apnea and sleep deprivation syndrome, which was strongly significant for this girl. And this is one very good diagram which I found from the internet. There is a group of shared features between obstructive sleep apnea and PCO. So there were a plethora of clinical, signs which could relate to both obstructive sleep apnea, sleep deprivation, and PCO. And this was again one figure which showed how strongly sleep disturbances are linked to PCO. So routinely never miss out on taking a sleep history and a gut history when you're dealing with a case of PCO. Otherwise, your prescription will not be complete. You're not approaching her holistically. So I think this has been talked about, but this too much of anti-obesity drugs is not required for us. I just thought of including the pictures for the sake of completion, and these are the type of bariatric surgery well elaborated by Dr. Sunil. So even take home points have been given, but Ferriman-Golgi score is something which we can use for an OPD assessment because that forms an excellent tool. I use that routinely in my OPD, which my staff fill up because that's a subjective assessment, and you also get a prognostic value when you meet the patient again after 6 months for follow-up. Are there any questions or? Okay. Thank you. Thank you. Okay, so we move on to case 3. A 34-year obese lady with BMI of 37, diabetic for last 1 year under hypoglycemic agents and hypertensive for 2 years. She was an IT professional. Both husband and wife are IT professionals. So these are common case scenarios presented to the OPD, anxious for pregnancy. So only after 3-4 years of marriage have passed, they think of that they want to conceive a child now. So they stay together but have infrequent intercourse due to work schedule and night shifts. And they also had sexual dysfunction because of obesity. They had sexual dysfunction, also significant sexual dysfunction, which is not in the purview of today's discussion. So they have undergone 3 to 4 cycles of ovulation induction with clomiphene letrozole and timed intercourse, but has failed. Okay, my first question will, Dr. Sunil, is what metabolic parameters, what other things, because she's hypertensive, she's diabetic, as far as the wife is concerned. So any other metabolic parameters you would like to evaluate for her and her husband?
Yes, actually, diabetic, hypertensive, and also infertility having been subjected to a number of procedures. So yes, first and foremost, the glucose parameters, the HbA1c, fasting PP, and apart from that, cardiovascular risk reduction is also equally important at this age. So good lipid profile, liver function test, and then yes, as for any other PCO cases, the TSH and free T4, serum prolactin. These would be my basic tests.
Yeah.
And I would be like to put concise over here because one of the question is that can we rename it? So I was actually going through the internet. I have listened to some of the fancy names in some of the conferences, but then the two most important names that came to my mind was like metabolic reproductive syndrome or hyperandrogenic metabolic syndrome. These are the two terms probably
this is much talked about these days. I think one of the last questions for this case is also that, so any name change owing to the plethora of metabolic derangements, because polycystic ovarian syndrome is basically looks like a misnomer. This syndrome is hardly restricted to ovaries. Infertility is just one of the many presentations that the patients can come with and the clinical problems that they are dealing with. So name changes have been suggested by multiple PCOS societies all across the globe. Even the PCOS Society of India was asked to suggest one of the names, and that was one of the questions for this case as well. So I'll just show you one slide after this. Okay, Shilpa ma'am. So owing to their lifestyle, when nowadays that very often in all metro cities and probably in every city of India, home cooked food for dinner and for breakfast, it's very rare these days. And both of them being IT professionals staying alone in some metro city, and they're not likely to have home cooked dinner at least 5 days a month. I'm not likely they would be having. So what would you suggest them, like what can they do at such morbid obesity for both of them seeking fertility? So what would be your nutritional advice for them?
So first of all, it's very important for them to take nutritional advice seriously. And I think a very good way to do it would be using a CGM where they'll find out that, if things are okay 2 hours, they are not okay in between or within 2 hours. So glycemic variability is something that this lady might understand if she puts a CGM. But beyond that, your question is very right that a lot of people really do not reach home on time and have no avenues to eating healthy. I do not know about other cities, but cities like Mumbai, Pune have a lot of healthy eat out options wherein there are actually dietitians who cook meal of a certain calorific value and send it to your home. So there are services available at least in metro cities where you can get. Otherwise, you can have a home help who comes and sort of makes it for you while you are not there. But I think it's very imperative that you eat healthy, homemade, fresh food. The recent term for it is 0 kilometer diet. I don't know if you have heard that. It's called
No,
0
ma'am.
kilometer diet. Means you eat what is what is available in your vicinity of 0 kilometers. Do not go and eat something which is not grown where where you live. So if you are, say, for example, living in Maharashtra, there is no need of eating a red yellow capsicum or avocado or a broccoli because it doesn't grow in Maharashtra. It grows somewhere else. In India, it grows in Hyderabad. It doesn't grow anywhere else. So I think things like that, I think 0 kilometer diet tells you that you have to eat local, you have to eat fresh, you have to eat seasonal, you have to eat unpackaged. I think these are things which are very important. Don't eat out of a packet. And when I mean a packet, it necessarily doesn't have to be processed food. It can be anything. Even food that comes from your Swiggy and Zomato does come in a
Exactly.
packet ultimately. I think very, very important is being conscious and also
Absolutely.
changing the understanding of food. I think that's very, very important. So, for example, when I talk to young couples and I tell them, you can have salad for dinner, the first thing they will tell me is, but madam, वो तो salad है, खाना क्या खाए? Salad is khana. I think that's something that they need to understand, that a bowl of soup is a meal, a bowl of salad is a meal. And if that is something not there, then I really would suggest meal replacement for such people. Because in this case, with her BMI, which is somewhere around 35, 37, I think weight loss is going to make, whenever she gets pregnant, by
Absolutely.
whatever
Yeah.
mode,
Yeah.
it's going to make her life easy. It's going
Yeah.
to put her sugars in level. It's going to put her blood pressure back to a lower range. So and even her lipids, we don't know what her lipids are, or maybe she also has a fatty liver. We don't even know that. So all of that levels are going to go down. So I think eating well means good food. Good food, what I mean is, like what I said, uncooked, unprocessed, minimally processed kind of food, very, very important. Looking at
Absolutely.
certain things like nuts, seeds more critically as snack options as compared to a bag of chips or biscuits or whatever it is. I think that's
Right.
very
Right. It's important to start on the diet, but they're not compliant for a long time. That's very important. And she needs to be counseled that even when she becomes pregnant, there are going to be a lot of complications with this weight. So she has to bring down her weight before she, at least 5-10 kg, 5-10% of what is her existing weight before she becomes pregnant. Otherwise, it's very difficult. And it's important for her to stick to the changes that she makes. They want
so
instant results, ma'am, always. अभी
no,
किया
no,
एक
that
महीने
is
में कुछ नहीं हुआ.
instant result है, वो तो ठीक है. What happens is when they go through a weight loss cycle, in 6 weeks they hit a weight loss plateau, which is very
Absolutely.
physiological, which happens. But the
Yeah.
point is, you cannot lose your heart there. You have to wait out the plateau and restart weight loss. And that's
Exactly.
the bigger
Yeah.
problem in their case. And a lot of people talk about a lot of variety and we want to eat this or bahar kya khaye. But if you hear people who are dedicated to say sports or who are from Bollywood, you will hear these people saying we eat the same food all 365 days. So
Right.
most of the professional sportsmen do not eat variety because they want to maintain their body weight at their body fat percentage at a certain level. So while enjoying once a while is okay, your everyday meal cannot be enjoyment. It's a source of energy and it has to be
Exactly.
a particular
It's
kind
not
of
a source
food.
of enjoyment, right?
Yeah.
Right. That should not be an like I'd read somewhere that food is the most abused anti-anxiety drug. So that's and exercise is the most underused
Underutilized.
antidepressant.
Yeah.
So exercise is underused and food is used as an anti-anxiety thing. Okay. So I think bariatric surgery question because if she goes for bariatric surgery, she has to postpone her pregnancy by 1 to 2 years at least because she herself will be nutritionally deprived and therefore the fetal nutrition will be compromised highly and therefore going for bariatric surgery is a personal choice. But yes, that would be a very good suggestion for this couple, for this with this metabolic parameters and BMI. Okay, Dr. Pallavi, what would be a line of management for her fertility issues? Do you think at this weight her oocyte and sperm qualities would be affected and your ART success rate is impacted with this sort of BMI and pregnancy complications, if any?
Yes, ma'am. So this patient, she has a multiple factors that can affect a pregnancy. Most importantly, she is obese. Along with she has diabetes and hypertension, and along with that, she has all this stress from work, and they have sexual dysfunction as well. So there are multiple factors, especially this metabolic parameter like the diabetes and which is a high stress condition for the body, which cause like oxidative stress for both male and female, and especially in the female all these metabolic conditions can affect her oocyte quality, especially if she is PCO along with obese along with hyperandrogenemia is there. which can affect the granulosa cell function, which can cause increased meiotically incompetent oocytes. Along with that, the proper maturation will not be there, so that will greatly impact her oocyte quality. And even in the male also, there is the same stress factor. The oxidative stress can affect the sperm quality as well. So that will definitely affect the embryo quality, their implantation rate, and even if implantation happens, the high risk of miscarriage in this couple.
Absolutely. So fertilization will also be impacted, blastulation will be impacted, implantation will be affected. Yeah, every level of pregnancy when she's trying to conceive will be affected, and the pregnancy also will be full of complications.
Yes.
Yeah. Yes. So that's how we counsel.
Yes.
Okay. Any name change, Dr. Sunil, Dr. Pallavi, Shilpa ma'am, any from your side, and then I'll show you one slide which I got from one of the PCOS Society presentations and which was very interesting. I'll show you that. But any name change, Dr. Sunil, do you think there's any better name for PCOS? Just to give an impact of how multi-system involvement is significant for this syndrome. It's not restricted to ovaries.
So one such term which is gaining traction across the globe, and I have also listened to it quite a good number of times, is the metabolic reproductive syndrome. That strikes my mind. And then there are a number of others, but this is something probably which would be more apt to describe this syndrome holistically rather than naming it as simply polycystic ovarian syndrome. Metabolic reproductive syndrome.
Exactly. Dr. Pallavi, any suggestion? Like, have you ever thought, because it's not restricted to ovaries?
In the X-ray guidelines and all, they are also writing, like, for the name change, they're taking a survey. So they are giving multiple terminologies which you will choose, like they are giving. So if you want to keep the name PCOS, then similarly you can choose like polyendocrine chronic metabolic ovarian spectrum disorder.
Polyendocrine chronic metabolic is one which is suggested from many societies. But I think, so why was it actually required? Because it because we need from the name only, no? Syndrome should reflect the core features of the disorder, which include hormonal imbalances, ovulatory dysfunction, various physical symptoms. Also, it should include the metabolic component and the multi-system involvement and multidisciplinary approach that this syndrome requires. So it's not restricted to gynecology segment. It's not restricted to ovaries. So this was the list of names which was suggested. You know, like I was surprised to see polyfollicular ovarian syndrome, because the cyst itself is a misnomer. Those are not cysts. They are unruptured follicles, basically, where the growth and development of the follicle is arrested at a state. So they are polyfollicular ovarian syndrome, hyperandrogenic anovulation syndrome, metabolic reproductive syndrome, hair odd syndrome, where odd stands for ovulatory dysfunction, or Kaha MS syndrome, which is chronic anovulation, hyperandrogenemia, metabolic syndrome. So these were the names. And one very important thing is that our radiologist colleagues often write PCOS in the ultrasound report. So we should be emphasizing at an individual level that it is polycystic ovarian morphology in the report, and it's not a syndrome. So you can write clinical correlation required. And for major group of patients, polycystic ovarian morphology is not mandatory for diagnosing the syndrome. So the ultrasound should always write morphology. So in polyfollicular or hyperandrogenic anovulation syndrome, or like Dr. Pallavi mentioned. So what was like the name which is most often suggested and talked about in our society is female metabolic reproductive syndrome. So I think this will cover everything. So one of my patients, actually, her mother asked me, I have a son, so what is the male counterpart? I told it's metabolic syndrome. So female and reproductive is hata do usko, and it's metabolic syndrome. So what other male counterpart do you need? So basically the most appropriate name as of now would be female metabolic reproductive syndrome. I think most of you will agree. Yeah. So I'll skip the take-home points. This is the last case. We'll just touch the important points. A 42-year-old obese woman with BMI of 37. She came with irregular periods. She's 42, so she is in the perimenopausal age group with bloating and depression. Ultrasound showed bilateral PCOM long back. She was a long-standing case of PCO long back. Even her reproductive period was, lot of turbulence was there. She conceived with ART procedures. On evaluating, she was found to be a diabetic, known case of hypothyroid for last 3 years on medication. She had a history of sudden weight gain of 10 kgs over 8 months. She was worried about her hair fall, excessive unwanted hair over chin area. I just want to emphasize 1-2 points in the perimenopausal age group, which I've learned over years of practice. I think Dr. Sunil will also agree. All the hyperandrogenic features actually have a rebound tendency to come up in the perimenopausal age group. So that is what I wanted to bring to your notice through this case. And there was, too much of hair over the chin area and over the mustache area, even the sideburns. So that was very prominent and it was affecting her. So she was 42 only. She feels irritable very often and have significant body image issues as well. She seeks your help. So like metabolic parameters, this part we'll skip. Lot has been discussed. just about that. Okay, bariatric surgery, yes, we can think of because she's morbidly obese, and maybe bariatric surgery will bring down 20-30% of her weight, and these symptoms will come down to a certain extent. Maybe she'll have a positive body image as a consequence of that. Shilpa ma'am, any specific diet like you like to give for this perimenopausal age group with a metabolic derangement? A female who is perimenopausal, like certain soya isoflavones or any dietary supplements or diet recommendations for this age group female?
So very important. I wanted to emphasize 2 points in case of perimenopausal women. The most important one is weight training, because this weight training will help her to get flexibility, develop bone mass, develop muscle mass, whereby a lot of these problems will solve. Weight training is never more important as it is in perimenopausal. I mean, it is always important, but it is especially important in perimenopausal time. Other than that, I think in perimenopausal age, because I am also in that age, so more than a patient, I can relate to it as a person, to sort of let go. Psychologically, you're like, farak padta, it doesn't matter. Let go. That's the whole problem. And I think that creates all these problems. So it's very important to be in control. And so, yes, soya isoflavones will help. Going, having a lighter vegetarian high protein diet helps. We see all these things. Also, there are a lot of IBS kind of symptoms which come up.
Exactly. They have a lot of gut issues.
A lot of gut issues which come up. Like you said, there is a lot of hirsutism which is seen in this age group.
Yeah.
All this actually, so we always emphasize on a very high fiber diet at this point, high amount of proteins, but weight training is very, very important. And of course, you can, like you were speaking about nutraceuticals. So at every age, think of nutraceuticals, A, as nutraceuticals, or B, as ingredients which come from natural food. So say giving soya isoflavones is important, but say if there is a woman who really does not have symptoms of hot flashes or any other thing which demands isoflavones per se, try to give her foods which could contain isoflavones, which are like soy and tofu and soy milk and so on and so forth. I think that's very, very important.
Exactly. Yeah. And very important in this age group is that because the physiological antagonizing hormone for androgens is estrogen, and it's coming down in the perimenopausal age group. So I feel menopause is less turbulent than the perimenopausal age group, ma'am. I think you would also agree to this, that perimenopausal women are much more stressed compared to an established menopause. So they are very stressed because the androgen doesn't increase per se, but because of the antagonist decreases, estrogens come down gradually with starting from perimenopause in a gradual manner. Therefore, the androgenic excess actually manifests as hair loss, as alopecia, as putting up truncal obesity and all, which bothers them more because they are more concerned about their body image. So I think the best policy at all ages would be to let go, really, ma'am. Because
these days, I wanted to say, gamma-linolenic acid really helps with mood swings. Okay. It really helps a lot with mood swings which are associated in perimenopausal age. If you can give them as nutraceutical, it's one thing, but if you're not, then try to include a lot of seeds in the diet, which is a very, very rich source of gamma-linolenic acid. So if you can include a lot of seeds, you will see that they do well. But yes, if you can give it as a medication, as a nutraceutical, it will really help with mood swings.
Okay. Madam, can you help with some of the preparations those are available? Gamma-linolenic acid.
Primoza.
Acha.
Okay. All right. So, Pallavi, do you agree? Do you evaluate your perimenopausal patients for like breast and endometrial cancer? How do you screen? And if they come with irregular cycles to you with, they are obese, they have been a case of PCO for a long time now, and they come to you with perimenopausal symptoms as well. Do you agree taking an endometrial biopsy or taking the menstrual history in detail? Do you ask all of that?
Yes, ma'am, especially in the perimenopausal group because they have a prolonged unopposed estrogen exposure, all of them.
Absolutely.
And one more thing is they are higher weight. PCOS, they can be like higher weight and they have other metabolic parameters. So they are at very high risk for developing breast and endometrial cancer. So especially if she has a prolonged irregular cycles with a prolonged cycles. So they should be usually screened for higher endometrial thickness and regular progesterone withdrawal has to be given for a
Right.
measure to prevent endometrial
Right.
cancer.
Especially if she has had anovulatory cycles throughout her reproductive age group,
Yes.
and she has had amenorrheic periods for 3 months, more than 3 months, it's very important to do a endometrial biopsy. Even
Endometrial biopsy.
if she doesn't complain about that, it's always useful to do it at least once in 2-3 years. That
Especially
will help her.
after 40 years, definitely we should go for.
Yes, definitely after 40 years. And it's very important, just like Shilpa ma'am told, a holistic approach, especially for these group of patients, like so lifestyle counseling, yoga, meditation, relaxation techniques, weight training, like ma'am told, and let go is the key, I think, to all age groups. So winding up the panel, I think one take home messages from all of you I'll take. So these are just summary flowcharts to link and to show you how strongly obesity is linked to PCO. This is one. You can see obesity, chronic inflammation, all of this is linked to PCO. So everything is basically an interlinked connection linking obesity, metabolic dysfunctions, chronic inflammation to PCO. So I think ovarian syndrome is just a small part of the entire metabolic syndrome affecting multiple organs. Therefore, for all cases of PCO, we need to give a holistic approach. Just like we discussed about sleep, gut parameters and all, it is very, very essential to approach the patient as a whole and not, deal with the complaint that she has come with. Because if you give her a holistic treatment only, her symptom resolution will be early. That's very important. And I think all of it has been discussed. Metformin, insulin sensitizers, GLP-1 analogs. I think we have touched all of this. So all of it has been discussed. And I think this was the best figure I could find linking all complicated, all hormonal imbalance, adrenal involvement, ovarian steroidogenesis, affection, and reproductive dysfunction, linking obesity and PCO. So ovary is here, metabolic dysfunction is here. So you can see you cannot rule out one from the other. So whenever you approach hyperinsulinemia, you have to give an anti-androgen as well. You never know that. Even I got to know recently that metformin has an anti-androgenic effect as well, a direct anti-androgenic effect. I was not aware of that. So every time we prepare and we learn for a talk and we discuss PCO more, we get to know the syndrome more and more. So even metformin has a direct anti-androgenic role as well. So one take home points from all the panelists, which I would like all of you to sum up. I think Dr. Sunil, you can start. 1 point on obesity and PCO, one take home point.
Yes, actually, it presents in a manifold manner, depending on the age, the adolescence, the reproductive age group, or the perimenopause. So not only looking at the ovary, we also need to look at that in a holistic perspective, and we also need to take care of the metabolic baggage that it comes along with.
That the patient carries. We are not aware of how much anxiety and depression she's in. That's very important. Usually the patients, the adolescent group, they come, they sit down, and their mother starts speaking. They're not ready to speak also. They don't look at the clinician also. So they're that depressed. So we have to talk to them, and therefore counseling is the cornerstone. Shilpa ma'am, one take home point from you.
I think lifestyle changes, what we need to tell our patients or clients is that lifestyle changes is not for 3 months, 6 months till they are coming to us for the treatment. Lifestyle changes for life. And I think
that's
because
true.
they keep saying ये 3 महीना करना है, ये 6 महीना
That's true.
करना है, ये बच्चा होने तक करना है, नहीं ये जिंदगी
Very, very common question, ma'am. Very common. So she will resolute her symptoms. At the end of 1 year, she and her mother will ask, ma'am, कितने दिन medicines लेने, कितने दिन diet पे रहना है. So lifestyle means lifestyle change. It's for life always. Dr. Pallavi, one message from you.
Yes,
One take home point.
ma'am, the first point that you told that first defining obesity, we should not just look that it is obese PCOS and lean PCOS. We should always look for their central fat deposition can also be very important, and we should not ignore the metabolic complications of syndrome.
Yeah, very true. Very true. So we have a dedicated unit on PCO where we have these booklets which we have formulated. I have at least to the limited knowledge that I have formulated a history taking sheet where sleep and gut issues have been addressed. At least my staff can tick that we are not missing out on sleep and we are not missing out on diet and gut issues. And we do this FG scoring as well as subjective assessment. Maybe for prognostication it helps, although clinically we don't find it much relevant as far as prescription is concerned. But I have a history sheet in which this is there. We also give diet and yoga charts because they are all used to internet. So if you tell them scan this and work out, they will work out. Okay, and you always, whether they follow or not, we make it a point to counsel, and we always get this pledge signed by patient, which is very essential. So at least you have done the counseling, you have explained them everything, and whether they follow it or not is up to them. You cannot do everything for them. So we give our 100%. So at least for our satisfaction, we do this. We get a pledge signed that you have followed and we have counseled you regarding this. So even we have training programs, and every time I do a training program, I actually learn more from the trainees. So PCOS is always a Pandora's box. Even today from the panel, I learned so much. Thank you, the experts panelists, for joining, for contributing your ideas. So education is actually progressive discovery of our own ignorance. Knowledge is learning something new every day. Wisdom is letting go of something every day. So just like Shilpa ma'am aptly told, let go. So it's like they say that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So every time we have to unlearn something wrong which we knew, and we have to learn something we didn't know. Thank you very much for your patience. Thank you very much, experts, for giving me your valuable time. So thank you so much.
Thank you.
Thank you so much.
Thank you, ma'am. Thank you, ma'am.
Thank you. Thank you.
Thank you.
I think we can wind up. Thank you so much, ma'am.
Yes,
Thank you, Dr. Sunil, Dr. Pallavi. Thank you. Thank you so much.
Thank you.
The recording has stopped.